I'm here today, yes, talking about perioperative hypersensitivity. It's a topic I personally like a lot. There is a lot to discover in this field. I'll try my best to stay on time, and I hope I didn't put too much content in the top part of this slide, since it seems we are facing some technical problem. So perioperative hypersensitivity, it's a broad definition, is a broad topic. But basically, when we try to identify what's the time line of perioperative reactions, we basically include whatever happened from the time of the first administration of preoperative medication till the time when the patient is transferred outside of the ER to the post-surgical care. And so these include all premedication, induction of anesthesia, maintenance of anesthesia, and recovery and from anesthesia. Oh yeah, so this was skipped. So I have why it's so important and so difficult, and why we do have to identify as a special topic, because the setting is definitely different from the classic other settings in which a severe hypersensitivity reaction can occur. So what's special about OR and anesthesia is that all the attention is focused on something else. So all people are following the surgeon and looking inside the body of someone and not looking at other important part. There are a lot of medication given in short time. The patient is almost invisible to the eyes of the anesthetist as well, and the surgeon. And there are a lot of confounding factors, a lot of hemodynamic active drugs. So which are the mechanism of perioperative hypersensitivity? So there are immune-mediated reaction, and there are non-immune-mediated reaction. Among the immune-mediated mechanism, there are the specific reactions, so mediated by IgE or by IgG. And there are non-specific reactions, the one that occur through complement activation, and also through direct activation by the drug to specific receptor on the surface of mast cells, in this case, or also basophils. And then there are the non-immune mediated reactions, so the one that involves bradykinin system or the inhibition of COX-1, for example. These it's a representation of our mast cells. You see on the right, the specific. Of course, IgE mediated reaction are the most famous one, the most common one, most likely also the most severe one. But other reaction, in particular, the direct activation of receptor like the MRGPRX, are gaining a lot of attention because they might account for a significant proportion of the reaction we see, especially cutaneous reaction or local reaction to drugs. So here you see what's the important difference. IgE-mediated reaction requires prior sensitization, tends to be the most severe, and occurs through IgE binding with the specific receptor on surface of mast cells and basophils, and usually happen upon exposure. Like classic example, penicillin most of the time is an IgE-mediated reaction, but also chlorhexidine. IgG, it's more theoretical. There are strong evidence in mice, in human less. Might be important in reaction, for example, to some specific drug like the NMDA, or in other setting to monoclonal antibodies. Complement, it's cause a reaction through activation of the anaphylotoxin complex, and can be important in some special reaction, for example, to heparin. And direct activation through mast cell surface receptor is probably important, so cause a nice proportion of reaction, usually more cutaneous reaction. There is a low affinity in general for this receptor, so concentration of drug needs to be pretty high. That might explain why this can be involved in local reaction to, for example, subcutaneously administered drugs. So moving on, what's the incidence? What are we talking about? So we are talking about a rare disease, but not so rare. So it's rare but important. So here you see the different incidents described in the literature in some of the major study. In particular, the one of the NAP6, we'll go on this again later. So in the UK, that estimate an incidence of one like moderate to severe hypersensitivity reaction every 10,000 surgical cases. And this was reproduced in another study in France with very similar rate. What do you see here? There is a huge heterogeneity, probably justified at least in part by underreporting of reaction. Some of these are managed in the OR, are not reported, patient is not accounted for, or hyper reporting when you are focusing through a study. And what's the mortality? It ranges a lot. Overall, from 1.4 in the, for example, a study in Western Australia, to 4.5% in other case series. So clinical manifestation, classic. We already talked about anaphylaxis. What's the special setting here? So we know that part of this can be seen, not in every patient, but most likely skin is likely to be involved up to 90% of patients. What we have here as a special option, that skin is frequently completely covered by drape, and there are certain drugs that can cause flushing, so it might be misinterpreted, at least at the beginning. And so it might be totally not visible as swelling of the larynx in a patient which is intubated and sedated. So the respiratory system, we can have bronchospasm and desaturation, but bronchospasm can manifest itself only as an increase in the pressure of the air in the ventilator, or can be interpreted as a tube malpositioning or as a PNX, which can be seen in pneumothorax during mechanical ventilation. And the cardiovascular, so low BP, increased heart rate, or collapse, or cardiac arrest, can be interpreted at the beginning as pharmacologic effect of drugs, or hypovolemia, which is another very important differential diagnosis, or as hemorrhage. So what are the important things in diagnosing this? Of course, early recognition, so training of the anesthetist in identifying this problem. It should always be considered if our patient develops skin plus cardiovascular or respiratory involvement, and can be considered when there is only hypotension or tachycardia, especially if it does not respond to classic maneuver put in place to counteract this, like a bolus of fluid or a vasopressor. So bronchospasm should always raise suspicion in the anesthetist. And of course, the absence of skin signs should not be considered a way to exclude the diagnosis. But on the other side, isolated skin involvement should not prompt a very aggressive management, but on the contrary, increased monitoring to detect early signs of progression. So the differential diagnosis, of course, can be broad. It's not our main interest right now, but there are many confounding elements and factors that can be mistaken as a perioperative hypersensitivity, including effect of the surgery, effect of medication, or other disorders. So to help with this has been developed from ISPAR, which is an interest group on perioperative allergy, a tool which is available online that, with a very quite complicated grading system, helps you in identifying what's the chance of a reaction be real perioperative hypersensitivity. As you see, typical features give you a positive value, while atypical features gives you a negative one. And like summing everything and incorporating also the value of the tryptase, you can have a score that gives you a quite good positive predictive value in diagnosing perioperative hypersensitivity. Okay, so the grading of it's very similar to the one in general of anaphylaxis. And let's go a little bit more in detail. So in the acute phase, how is our assessment? The only few things that can be done in terms of diagnostics are serum tryptase, very important. This is a decision that needs to be taken in the OR, so there is no allergy consult that can be called, even if sometimes I do pick up calls from the OR from our anesthetist. Tryptase is very stable, so it's very important to draw even in very severe reaction because can have a very important medical legal value. The best timing is within 30 minutes to 3 hours from the onset of the reaction, in which after this, if there is no more release, the level of tryptase tends to decrease pretty fast. And it should be always compared to a baseline tryptase level drawn at least 24 hours after the reaction. This is the formula. We already saw this. Increase the positive predictive value, applying this instead of using the upper level of normality, which is 11.4 nanogram ml. And it's not always elevated, so it cannot be used to rule out perioperative hypersensitivity if normal. So what's the principle of investigation here? So from the anesthetist point of view, what they have to do? Acute management, take the tryptase sample in the acute phase, and then recording, okay? This is very important, recording the events, the reaction, the timing, the medication used, evaluating potential confounders that may be easily identified in the OR, but impossible to identify for the allergist after 2 months in the clinic. And of course, reporting, educating the patient. So the patient needs to know what happened so that can take, can understand also the importance of the next step. From the allergist, what's the point of view, our point of view? We need to review the record. And so we need to have access to the record. We need to review the history of the patient that maybe was not looked into in details. We need to select in vivo and in vitro investigation, plan a challenge if that's applicable, and then give at the end a risk assessment for future anesthesia. So from one side, we need to have adequate information, and on the other hand, we need to provide an adequate plan. So these are the steps of allergy investigation of perioperative hypersensitivity, which are similar to any other allergy evaluation for drug reaction. Gathering information, planning, testing, a challenge if possible, and make a plan at the end. So gathering information, our referral form ideally should include the characteristic of the timing of the reaction, the medication and the orders, the last medication given before the reaction, and the test if done during the acute phase. What we should review: patient medical history, previous drug allergy, other comorbidities, chronic treatment, results of the test, if available. So what's the correct timing of testing? From 4 weeks. So whatever it's earlier can be misleading, as you know, even if some guidelines suggest the, for example, measuring specific IgE, even in the sample of the acute tryptase, for example, for chlorhexidine. But let's say from 4 weeks to 4 to 6 months after the reaction is the ideal timing. All medication given from 1 hour for IV or oral, 2 hours for oral medication should be considered as a possible culprit. If a medication was administered again after the reaction, but in the setting of, like, for example, vasopressor infusion, should not be considered like, oh, that's safe because they received it again, okay? But a medication could be considered not suspicion if was given again in the next days, for example, propofol for during ICU admission. So these from the NAP6 audit project are the most common culprit. The funny thing is that these are assessed like at the end of the study, but it's nice to compare what was the perception of the anesthetists during the reaction. And most of the anesthetists always blame the NMBA for cultural perspective. And now we know that for most of the countries, that's not true. It's the antibiotic, the most common agent, culprit agent, followed by the NMBA and by chlorhexidine, and then a miscellaneous group of other possible culprits. What we know, I'll try to go a little bit quicker. So antibiotic were the most commonly identified during the NAP6. And there was a huge number of patients reacting to teicoplanin, which is not a problem and issue in many other parts of the world. The very important thing about this is that teicoplanin was used in patients with a history of penicillin allergy that were not delabeled before the procedure. So the labeling of penicillin allergy can decrease the chance of having a reaction to other antibiotic. NMBA were the most commonly suspected one, but not the most common one, can induce severe reaction. There is not really a significant difference among the agent apart from succinylmetonium, which is the most commonly involved in the reaction. Of course, this can vary depending on the local prevalence of use. Okay, so what you use locally tends to give more reaction. Chlorhexidine, very important. It's the most commonly used disinfectant. So there are quite a number of reactions, but if you compare to the number of time in which it's used, it's not really common to have chlorhexidine reaction in terms of proportion. It's always present in an OR unless it's a specifically chlorhexidine-free environment. It's present on the tip of catheter IV in gel used for disinfection, skin preparation. So very commonly our patients are exposed to chlorhexidine. Okay, 9% of cases. I just move a little bit quicker. And of course, it presents as hypotension, isolated, which makes things more complicated. Which are the other culprits to consider? So sedatives, which are very commonly used, are very unlikely to be the culprit of perioperative hypersensitivity. Dyes, patent blue is the fourth most common, and it's used especially in oncology setting for the sentinel node. Colloid and plasma expander now are reused pretty rarely, were more common in the past. Opioid and NSAIDs are usually causing non-IgE mediated reaction, tends to be less severe, but of course can be considered among the causes. Antiemetics, ondansetron, can cause hypersensitivity reaction, frequently overlooked. And latex, now it's like in my practice here, I haven't seen really a latex reaction since years, so not so common. And excipient, big headache for the allergist, possible, probably not common, but always remember in patients who test negative to consider this option. So how do we start the investigation? So the first step is always with the referral. And this is our typical patient I get to see in my clinic, which is patient is sent for evaluation without any record, unaware about the reaction, and for an event occurred years before. So in this setting, my role is almost zero. I very rarely can help this patient. So that's very important to have proper tools for referral. This is again taken from NAP6. You see our 4 pages of referral form that contains all the information that we need from the time of the reaction, the type, medication use, the sequence, and the type of investigation that were taken. And this can help a lot. So in vitro testing, we already said about tryptase. Specific IgEs are available only for few selected drugs and not everywhere. Penicillin, so the penicillin oil is there. Cefaclor is available. NMBA are available in certain places, as well as chlorhexidine. Chlorhexidine, for example, has a very good sensitivity and specificity, but it's not easy to get. We don't have it, for example, here. Usually do it quickly because after 4 months in this kind of reaction, level of IgE tends to drop. So basophil activation test, very nice and promising tool. I would say difficult to obtain in centers which are not experienced on the topic. You need expertise, you need the freshly drawn samples. So definitely, if you have it, great. Otherwise, frequently you have to do without that. In vivo testing, as you know, skin prick test and intradermal testing, always remember, use the published non-irritating concentration. For some of the drugs, these are not available, like, for example, ciprofloxacin doesn't have a non-irritant concentration, so don't skin test ciprofloxacin. Include panels sometimes, so an MBA is very important to run a panel, so the culprit agent and possible alternative. DPT, great, is the golden standard therapeutic dose, but very difficult to perform in this setting. There are few specialized centers around the world, for example, in Denmark, in which routinely drug provocation testing with the NMBA or hypnotic agent are performed in the presence of an anesthetist. And these have like a very important role, but of course, we cannot consider them as a routine practice apart from few selected drugs like NSAID and opioid. So what about if all the tests are negative, which is not such an uncommon occurrence? So first of all, reconsider the reaction. Was it really hypersensitivity? Am I missing something? Discuss with the anesthetist, reevaluate the exposure. There was something I overlooked, something was missing. Latex, for example, or disinfectant were not recorded, or a dye, or contrast media, for example. Consider the excipient. Reevaluate the investigation. Did I do something wrong? Maybe the patient was taking a medication that was interfering with my skin testing. Should I repeat the testing? And consider other disease that can cause frequent reaction. But if, for example, there is a low suspicion, consider alternative explanation. Maybe it was not perioperative hypersensitivity. Is there something else that can explain the reaction of my patient? And reevaluate everything. And sometimes, like there is nothing, like patient doesn't have any valuable explanation. So what to do? Shall we go for a premedication? Highly debated topic. I usually tend to avoid premedicating patients in this setting. Might have a limited role only for milder cutaneous reaction, while cannot really prevent severe hypersensitivity reaction. So I generally what to do is I flag the patient as at risk. Anesthetists should be aware about the possibility of a reaction. We try to use alternative medication if available, and in the OR, they should be ready to intervene if there is any sign. So to wrap up, perioperative hypersensitivity is a rare but potentially very severe complication of anesthesia. And anesthesia, we understood now it's a very delicate time for many reasons, including the fact that the patient is not accessible and there are a lot of confounding elements. Proper investigation and referral can increase significantly the outcome. So if I don't have the information I need, it's very unlikely that I can do anything valuable for my patient. Antibiotics are the most common culprits, so always remember to include them. And NMBA and chlorhexidine are frequently associated. So especially chlorhexidine and latex always include in your testing panel. So the purpose of my investigation is potentially so ideally to identify the culprit, but at the end of the day, to minimize the risk for my patient for future anesthesia. Which are the major unmet needs? Okay, there is a significant gap of knowledge. Perioperative hypersensitivity doesn't draw a lot of attention from pharma, doesn't bring money. It's a cost for the insurance company. So there is not really a lot of interest in developing this field. Communication referral are frequently inappropriate, and documentation is usually very poor or inaccessible. So in these countries, not uncommon to have patients who come to me without records and that cannot access the record. They go to the hospital, they ask for the medical record, and they are refused to be given their records. And there is a huge lack of specialized center. Consider that as per guidelines, a center that consider themselves specialized in perioperative hypersensitivity should test at least 20 patients a year, which is a lot, okay? It's not common. And of course, most of the patients, at least I would tell you our local experience, might not be covered. So insurances, policies can decide not to cover investigation for perioperative hypersensitivity. Doing so, they are exposing the patient to a significant risk of morbidity on the next anesthesia. So I don't know if there is something we can do on this. That would be great. Thank you so much for your attention. I just tell you, ISPAR is the interest group collaboration with European Anesthesia Society and the Allergy and Immunology Society. Its membership is free. There is one annual meeting. So if you want to join, just go on the website and be part of the family. Okay, thank you so much.